Hello, and welcome again to another episode on CYC MD. In this series, we are examining different specialties and speaking with different professionals focused in their area of practice. Today, we will be talking about the topic of anesthesia. With me today, I'd like to welcome Dr. Ronnie Macarius. Welcome, Dr. Ronnie.
Thank you.
Pleasure to have you.
Thank you.
He will be answering many questions for us that we may have on the topic of anesthesia. So to start, Dr. Ronnie, I'd like to ask you if you could just tell us a little bit about yourself, your education, and where you work.
Well, I studied medicine at Stony Brook Hospital. I went on to do training as an anesthesia resident, which involved 1 year of general internship training, which I completed at Frankfurt Hospital in Philadelphia. And then I went back to Stony Brook to complete my full anesthesia residency training, which was another 3 years. And since then, I've actually had sub-fellowship training in anesthesia research. And right now, I'm working at Stony Brook as a junior faculty research member. And I actually have a couple of projects that I'm actively working on in my lab right now.
That's juggling a lot.
Yes.
So why anesthesia?
Well, anesthesia appealed to me because it seemed like it was a very hands-on type of specialty, and you get to interact with the patients directly, and there is a lot of medical knowledge that needs to put into place, but also you get to give medications and see the result of that medication that you're giving right on the spot. So it's almost that instant gratification that drew me in, and there's a lot of physics that goes into it, and physiology. And pharmacology, and these are my most interested subjects, so that's why I decided to go into anesthesia.
So what do you like most about your job?
What I like most about my job is that we try to keep things stress-free for the patients, because I know on a day of surgery you're going to go in and there's going to be a lot on your mind and you're going to be worried about this, that, and the other. So as an anesthesiologist, we try to make sure that the patient's nice and comfortable and that we try to relax them to kind of quell their fears. And so that atmosphere that we try to generate actually helps me too. So in the end, it's good for both the patients and myself.
Now, I know you went through many years of training, many years of schooling, and we all know that the road to becoming a doctor is a long journey. And even afterwards, even after you graduate, you're still taking exams. What would you say is the most difficult part of your job? Now you also have a baby, you have a wife, and I know to juggle family and even church time and also your job, and to juggle all that, it seems that there's just not enough time in the day. So what would you say is also the most challenging part for you? Well,
definitely it is a lot for one person to handle. And I have to say that I thank God that He's given me the ability, not just in and of myself, but I know that I rely much on all those people around me who helped not just to get through medical school, but even now when I delegate research responsibilities to other lab members, they step up and they help. In the OR, when we ask our colleagues, we always help each other out, and so there's a lot of camaraderie. And just in general, I know that I can do nothing just of myself, and it's always a team effort. And so that's what keeps me going, and that's why I'm able to do so much things, because I keep in mind that it's not just me by myself, but it's a team of us. So that's how I think one person can juggle so many things.
Good luck with that. So now to cut to the topic itself, what is anesthesia?
So anesthesia is the specialty in medicine where the doctor would try to keep a patient comfortable during time of surgery or a procedure. So if a patient would be going because they need to have some kind of, if they have to get their appendix out, the anesthesiologist would be the one to make sure the patient's nice and comfortable and sleeping through the operation, and at the end of the operation would wake up without any complications. Essentially, the anesthesiologist becomes the doorkeeper to the OR, because we monitor, we take a full exam and a history of each patient before they come to us, We make sure that they're the right candidate for the right procedure at the right time. And oftentimes this requires a lot of knowledge, not just of not just of anesthesia, but of all the different surgical specialties that we deal with, and a lot of medical issues that patients might have. And so we want to make sure that the patients are safe, and that's ultimately the anesthesiologist's role, is that the patients that go for surgery are safe.
What kind of training or education goes through to become an anesthesiologist?
That's a very good question, actually, because there are multiple different types of professionals who can administer anesthesia. There is anesthesiologist, which is usually a medical doctor. That anesthesiologist would have to have medical school training, which in and of itself is 4 years. On top of that, anesthesia residency training, which is another 4 years. And then after that, they would be certified. And they usually get certified with 2-part exam, which is one is a knowledge test based on a written exam, and then another is an oral exam where you have to discuss different cases with somebody who has been doing anesthesia for many, many years in practice. And then you get your certification to practice as an anesthesiologist. Now, there are other types of people who administer anesthesia, and that is registered nurse anesthetists. We call them certified registered nurse anesthetists. These CRNAs are allowed to perform anesthesia under the direction of anesthesiologists. In different parts of the country, however, they can administer anesthesia by themselves, but this is rare cases in different states. So in New York, for instance, where I practice, we are able to have registered nurse anesthetists work with us under our supervision, and they would be able to administer anesthesia because they're certified.
So how many years of schooling does a CRNA have to go through?
So usually, actually, they first go to nursing school, and they usually have to practice at least 2 years of nursing in a critical care type of field, so like an ICU or so. And then they go for CRNA school, which usually takes about 2 to 3 years, depending on which school you go to.
Break it down for us, Dr. Ronnie. What are the different types of anesthesia or different fields for anesthesia?
Okay, so those are kind of 2 different questions, but I'll try to tackle them both. The different types of anesthesia, we could give general anesthesia, which is on average probably much more common than any of the other types of anesthesia. General anesthesia means that you're completely knocked out, and usually that entails IVs, and we oftentimes put breathing tubes to make sure you're not going to move during surgery, and the machine breathes for you. So that's what we call general anesthesia. So usually people with general anesthesia have no memory or recollection of what's going on in the operating room. On the other hand, there are other types of anesthesia, which the best way to describe it is many people often would go to the dentist and they get numbing medication in their mouth, and you kind of have that feeling of that you can't feel your mouth. We use the same type of medication, and we give it either in the spinal column as a spinal, or similar as an epidural. This would actually block sensation, and depending on how much medicine you could give, it can be all the way from the middle of the chest all the way down to your toes. So any procedure or operation that needs to be done from here down, the patient would not feel anything that's going on. So for instance, a mom who doesn't want to miss the delivery of her baby would ask for a spinal, and that would would have her numb from the chest all the way down to her toes, and the baby can come out and she could actually be awake for that, because it's something that they wouldn't want to miss. In terms of other types, we could actually, if somebody were to have a procedure on his hand, like carpal tunnel release or something similar to that, we can use what's called a nerve block. So with using ultrasound or other different techniques, we can find the nerve that innervates the feeling in the hand, and we can give that same local numbing medication to that nerve, and that would anesthetize that part of the body for a good 12 hours or so, a few hours being for the surgery, and then a few hours after that for pain control. Now, you asked a different question, which was, what are the different types of specialties in anesthesia? Anesthesia does have a few subspecialties that are recognized. The first specialty that was recognized was critical care. Critical care is the taking care of patients who are very, very sick, and usually it comprises patients who are on ventilators, patients who have multiple infusions. These are patients who are very close to death's door. And the goal is to treat them so that they can recover from, if it's after a surgery or any type of procedure, that they would recover from that. And usually, if it's after a surgical, they do fairly well. So if everything is well controlled in a critical care setting, and that's one field of anesthesia. Another field of anesthesia is cardiac anesthesia. Cardiac anesthesia is a specialty where people are going for special surgery for their heart. These anesthesiologists train extra special because a lot of times they not only have to deal regular anesthesia, but they also have to deal with a pump when a patient goes on what's called bypass. That's why they call it bypass surgery. The patient will end up going on bypass because the surgeon is working on the heart, and so the heart can't pump. And so while the surgeon is working on the heart, they have a machine that both pumps the blood and actually oxygenates the blood. So this takes special training. Another field of anesthesia is obstetrical anesthesia, which deals with patients who are on the labor and delivery suite. And usually this involves patients who are giving birth. And this is a recognized specialty as well. And another specialty is pediatric anesthesia. Pediatric anesthesiologists actually have specialty training. They go through an extra 1 or 2 years, depending on the type of pediatric anesthesia they perform. And their specialty is to give anesthesia safely to children.
Thank you, Dr. Ronnie.
No problem.
We have so much more to discuss. We will be talking about the risks of anesthesia and so many more questions. We're going to come back with Dr. Ronnie after a short break. Welcome back. We are back again with Dr. Ronnie Macarius, an anesthesiologist at Stony Brook University Medical Center. So I guess the big question can be is anesthesia relatively safe?
Actually, anesthesia is very, very safe. At first, when anesthesia first came out, one can say that it was considered at the beginning not necessarily very safe, but over the last century, there have been many, many things that we've done as anesthesiologists as a group that has made anesthesia to be super safe. In fact, many anesthesiologists will say it's safer to go under anesthesia than to drive to work in the morning, and essentially the statistics actually back that up. So anesthesia is fairly safe, and the only times when we would be worried is if there was any family history of problems with anesthesia, or if somebody is very, very sick, like a critical care patient, then there's higher risks. But for the most part, anesthesia is very safe.
Would you say it's safe in pediatrics or in kids too?
Well, absolutely, it's safe in children. I would say one thing. I mean, this actually goes into what what my research is looking into. We're looking at the effects of anesthesia on the brain of a growing child, what we're finding at least in animal studies, is that there's some question as to the safety in the long term. However, most of the studies that we're looking at show that anesthesia can be safe, but what I would say is that unless my child absolutely needs surgery, that it would be life-saving, then I wouldn't go to have, like for instance, I wouldn't have my kid go to get a mole removed unless it was absolutely necessary and life-threatening. So I wouldn't want to subject somebody to anesthesia unless it was absolutely necessary. But most likely, most surgeries that people go for are very necessary surgeries, and it's very safe for children.
So almost like a risk-benefit ratio.
Absolutely.
What would you say are the risks that are associated with anesthesia?
Well, there are a few things that anesthesiologists are careful of, and the first and primary thing is we need to make sure that the heart and the brain are absolutely in good shape before anesthesia. If somebody is a little bit older and maybe has diabetes and other problems we want to make sure that his heart can tolerate anesthesia. And what I mean by that is that there is a high chance if somebody has these diseases that unless everything is controlled, like their blood pressure is controlled, their diabetes is controlled, etc., then they can have a high risk of having a heart attack. So in essence, an anesthesiologist's job before this patient would go for surgery, unless it was an emergency surgery, if it was a routine surgery that was planned for, we can do things to help improve that patient's care, and then anesthesia would be safe and they wouldn't have problems like a heart attack or a stroke. On the other hand, there are things that are not something that we can completely predict, but we can look in family history. Some rare conditions one condition is malignant hyperthermia. And malignant hyperthermia is a very rare reaction to inhalational anesthetics, which are the anesthetics that you breathe in to help you fall asleep. In this situation, a patient would burn too much calories because their muscles are overcontracting in response to the anesthesia. And for this, there's special medication that we give, and we give it instantaneously, and usually it requires an ICU stay and close monitoring, but most patients still do well with that. And what we tell them in the future is that they wear a special medical bracelet and let anybody know that they have to avoid certain types of medications in the future.
So you mentioned earlier epidurals and spinal columns and spinal blocks. What is the difference between an epidural and a spinal block?
So the biggest difference between an epidural and a spinal is where the anesthetic is actually going. If you look at the spinal column in most adults will end by the level of L1, and some adults by the level of L2, which is midway down your back. And so when we give a spinal, we go way below where the spinal column ends, and we put it in actual where the spinal column sits in what's called cerebrospinal fluid, and this fluid is distributed throughout the entire back. Now, the spinal goes right into that fluid sac, and it completely applies to all the nerves in that area. The epidural sits right outside that fluid sac, and generally it takes a little bit more medication, and epidurals can be much more controlled. So if somebody has relatively more sick patient with heart problems or so, we can control an epidural much more than with a spinal, because a spinal works very fast, whereas the epidural works slowly. Also, oftentimes with an epidural, we can leave a catheter in, kind of like an IV that stays in your hand. We have an epidural catheter which stays in your back, and we can continue to give you medication over a long period of time, whereas a spinal, we only give a one-shot spinal, and it only lasts for 2 to 3 hours.
What are side effects that are associated with epidurals and spinal blocks?
Usually there are very limited side effects in response to epidurals and spinals. It's more likely to get it with an epidural because we use a larger needle, but there is something called post-dural puncture headache. So this happens in response to placing the needle for the epidural. If it pokes a little too far, what happens is that a patient may have a headache after they get the epidural placed. So it most commonly happens in young female patients. So if you think about it, this is usually patients who are in labor. That's not to say that it happens all the time. It only happens less than 1% of the time, and in very skilled hands, it usually happens even less than that. So, but it is something that one has to keep in mind, and it's usually very easily treated as well.
How much anesthesia do you know to give each patient?
So each patient is going to be...
How do you know what to give each patient when they come in with their special case?
Absolutely. Each patient is going to be different. And we take each person individually and take a look at their medical history, see what kind of medications they're already on, see what responses they have to different medications, such as pain medications that they might be on. And we tailor our anesthetic to that, and most often we'll have what we call, we will have a calculated dose for most medications. So for instance, if medication requires X dosing, that's usually the dose that we start out with, and we could always give more. if a patient needs more, or we could give less if the patient needs less. And everybody is different. So what we usually start out with, the number that we start with, is usually very close to what the patient needs, and we are able to titrate within seconds how much anesthesia that we really need to give, and it works very fast. So the amount given can be adjusted very, very quickly. That's why anesthesia works so effectively.
So you somewhat tailor it to a person's needs?
Absolutely. You don't want to give somebody who's very old and has lots of cardiopulmonary problems too much medication, so we usually start very low and go very slow. Whereas somebody who's young and energetic and is very athletic, then in that person we can give more, and we know that it's not really going to cause much problems for that patient. How
do you treat someone's pain after surgery?
So pain is actually a subspecialty of anesthesia in and of itself. Pain management after surgery, though, can be dealt with. Most anesthesiologists are trained, all actually anesthesiologists are trained to deal with pain after surgery. There are multiple modalities that we can use, most common being IV pain medications, and these include medications such as fentanyl or other opioid-type medications. Morphine being very common, or Dilaudid being very common. Other medications that we can use, for instance, an epidural can be a very, very effective way of controlling somebody's pain after surgery, because we can give medications through the epidural, and it will really involve only the area that the surgery was on, and you wouldn't have any of the mental side effects, and it wouldn't slow you down because it's only given right to the site where it needs to go. Also, we can do nerve blocks and leave catheters, and that can, so if somebody's having a surgery on his hand, he can have a catheter sitting in his shoulder, and that would give local anesthetic to that nerve, and he would have full function of his hand, but he also wouldn't be experiencing the pain that he would have if he didn't have that catheter in and the anesthetic going there. So there are multiple modalities. A lot of times patients, if they're having a lot of pain, anesthesiologists would choose to give them what is called patient-controlled pump. And basically, that's when you have a button in your hand and you could press the button and the machine would automatically give you medication as you need it. This can be working with an IV medication or an epidural medication as well.
Now, why do they tell patients not to eat prior to surgery?
Well, this is actually very important. Usually, when we're sitting in, when the patient is in the operating room, they're lying down on a flat table, and usually they may be going for a general anesthetic, depending on the type of surgery that they're having. And you could imagine that while you're awake, you're able to, if you're having anything in the back of your throat, you start coughing. You try to get it out of your system. But if you're asleep and you're not feeling that there's something in the back of your throat, you wouldn't be able to do that. So if you have something sitting in your stomach and slowly it creeps up your esophagus and goes to the back of your throat, you won't be able to protect your own lungs from the damage that that acid substance might do from your stomach. So what we want, the goal of it is to prevent any pneumonia that can arise because of acid leaking from your esophagus to your lungs.
So what would you say, like how many hours before surgery should you abstain from food?
Well, it differs for different things. You wouldn't want a little baby who's a newborn to wait 8 to 10 hours before eating before surgery. And so if you're breastfeeding, usually they say it's okay to go 2 to 4 hours without eating. If, on the other hand, that you're formula feeding, we absolutely say 4 to 6 hours before. And then in general, if you have an early morning surgery, the best thing to do is not to eat anything after midnight. But if you're having a later in the day procedure, I would check with your doctor first, but most times they'd say you could have maybe a coffee or something small in the morning, depending, but they want you to make sure not to eat anything for at least 8 hours, if not more sometimes. So I would check with your doctor first.
Can you share with us, Dr. Ronnie, maybe a situation or a case, something that throughout your years of experience, throughout your years of working, has influenced or touched your life?
Absolutely. I can remember a couple of cases But one of my more favorite things that happens on a day-to-day basis is every once in a while you'll have a patient who comes in with their family, and of course anybody who's going in for surgery tends to be a little bit worried. And it really is touching when you see that these patients are praying before they go for their operation. It happened to me a few times actually, and I was very happy to see it. Sometimes I actually joined with them. There was one case where we were in the operating room already. They were lying on the operating table by themselves, and they said, "Please give me a minute so that I could pray." And even though some people in the room were not very comfortable with that, I said, "Please take your time, we're here for you." And so it was actually very touching. So.
Sort of, because it maybe even relaxes them to be able, it gives them that peace to be able to sit through this surgery.
And then we know that God's on our side. So.
Yeah, definitely, definitely. Thank you so much, Dr. Ronnie.
Thank you for having me. It's a pleasure.
Thank you for joining us today on this episode on CYC MD on anesthesia. We hope you enjoyed our episode. We hope we answered many of your questions. Thank you so much, Dr. Ronnie. He helped us so much. We learned so much from him. And if you have any questions, please feel free to email us. We'll bring it to Dr. Ronnie's attention. Any questions that you may have, we can always direct it to him. Until next time, God bless. Thank you.